Today I'll be talking on ICU care of the post-cardiac surgical patients. And today we have experts on board because this is going to be very important topic. Dr. Meeta ma'am, Dr. Jain sir are also there. And this session is going to be highly interactive, totally interactive, I would say. I would request for participation from all of you. You can see ongoing CABG where you have multiple infusions pump. You can have on cardiopulmonary bypass pump is there. There are so many multimodalities for the hemodynamics are there. So this is going to be a classical ongoing CABG. Now, let us start with a case. See, such kind of case is going to be there in your e-cases in your exams also. A 55 male diabetic hypertensive shifted to ICU post CABG with IABP in situ. He is on injection dopamine and injection NTG. 1 hour after shifting to the ICU, BP falls to 80/60. So now the question is, what are the possible causes for this hypotension? I want all of you to write down the causes in chat box. And before we go further, while you writing down the key points to ask while you are taking over for the patient of the post-CABG or post-cardiac surgery patient, or to know few things while patient is being transferred to the ICU. One thing is detailed history of the patient, past comorbidities, any past medications, assessment of pre-op cardiac functional status. If any valvular surgery has been done, which kind of type of repair of the valve has been done. Any targeted vessels if CABG has been done. Duration of cardiopulmonary bypass, the patient has been kept on cardiopulmonary bypass since for how long time? And cross clamping. The duration is very important. The presence of abnormal bleeding, any any abnormal bleeding was there, details of any chest drains, how much chest drains are there within by the time the patient has been transferred to the ICU. Treatment given in the OT, like drugs which has been given, fluids, blood products which has been transfused in the OT, that must be taken over properly by the ICU team from the cardiac anesthetist. And important thing is check all lines and tubes, positions, patency and everything. And the important thing is do not forget to examine your patient. Okay, whenever you receive cardiac surgical patient, you need to remember all these things. And the important thing is do not forget to examine your patient. So now again, coming back to our case, please write down 55 diabetic hypertensive post CABG shifted to ICU with IABP on dopamine and NTG, BP after 1 hour 80/60. What are the possible causes for this hypotension? Okay, so many answers I am getting from Dr. Clem Jolie, cardiac bleeding, electrolyte imbalance, pharmacology, why did you have the CVG? Okay, more drain, bleeding, hemorrhage, NTG, tamponade, bleed, tamponade, cardiac tamponade, hemorrhage, clot of IABP, bleeding. See, post-op hypothermia, more drains, bleeding, perioperative infarct, graft spasm, active bleed, massive pericardial effusion. One or 2 minutes more. I'm waiting for your answers. Post-op surge-like response, drug effect, sepsis. You know what? While we discuss about something, it is not, sometimes it is not thinking about so big thing. As Sir Ma'am teach us that start from whenever you start thinking about endotracheal tube or any spasm, you start from tubing, vented tubing to the ET tube. So this is how you should think. You rightly said NTG, dopamine. So first thing, any clinking of the NTG, any flush of the NTG. So there are so many few minor things that has been taken also, and you need to think. So most common things are hypovolemia, bleeding, vasodilatation due to drugs, possible NTG, sepsis, IABP is there, so possible IABP tip malposition, possible cardiac tamponade, arterial line overdamped. You always, sometimes you are dependent on the arterial line waveform and it's overdamped. Arrhythmias are there, myocardial dysfunction and embolism. These are the major causes of hypotension while your patient just post-op CABG with IBP. But there are few things are also there, causes for the hypotension, particularly any drugs are going on, any tube is block of the particular infusion, that infusion tubing set has been blocked, any kinking of the tubing of the dopamine, any flush has been just by mistake by the nurse, flush has been given on the line in which line the NTG is going on. That may can also cause hypotension sudden. So for causes of hypotension, I would request Dr. Meeta ma'am as an expert after all these causes, any other causes or anything she would like to add on and share with us to find out about the causes of hypotension.
Yes. So many of you have participated. I'm audible, right?
Yes, ma'am.
Many of you have participated and many answers have been there which are correct. But I think when this kind of a situation comes, you should think not randomly, go systematically. Most of the things Dr. Vivek has put it up on the board. Of course, you need to think of technical problems, whether there's any technical problem and error, but think it is a post-CABG patient. So always think if whether it is a true low blood pressure, actual hypertension, and other than the causes which are there, couple of more other than IABP tip malposition, I think a faulty IABP setting is also very important cause of. In fact, that is the most important cause you should think if patient has an IABP, like early deflation, late inflation, kind of a things. Then second important thing is always think the patient has come from OT. Dr. Vivek already told you that you need to take the over. In that over, you need to know what grafts have been put. Number one, whether it was on pump or off pump. Number two, what grafts have been put, like arterial grafts versus venous grafts. One important thing is if the patient has got arterial graft, these patients will not tolerate hypotension. Very important to remember. Now, most of the places people have started putting Lima, Rima Y or Lima, Rima radial, Lima and radial, full arterial grafts. In these patients, at least for first 48 hours, you need to maintain a particular level of blood pressure. Otherwise, the graft closes and then patient may develop a infarction. Okay, so that is one very important thing. You need to know what grafts are there. Patients who have low ejection fraction or patients who have a high risk, like recent MI, those patients usually will have vein graft in a major vessel because veins can sustain hypotension. So that is one thing. So what is the reason of putting a vein graft and arterial graft? It is very important to know. And if it's a pure full arterial graft, you must avoid hypotension. So that is one while taking over. In the causes of hypertension, you must look for other than arrhythmias. So immediate causes, whether patient has developed arrhythmias. And number two, take immediate ECG because what if patient is infarcted? Post-CABG infarction is not uncommon. So if the graft is closed or there's a problem in the procedure technical, patients can develop infarction, post-CABG infarction. Other than these two, I think you have covered, especially you need to look at the drains because these patients who receive full heparinization, although they reverse with the protamine, if the patient is on pump for a very long time, then the reversal may be inadequate. Or if patient has received another important over, Dr. Vivek, I think already told you, if patient has received any blood products and how much fluid patient has received in the operation theater is also very important because these can develop what is called as dilutional coagulopathy. So if patient does not have arrhythmias, patient does not have infarction, if the NTG is not a problem. Of course, another important reason when it comes to technical is a ventilator. So faulty ventilatory settings. So if someone is put a very high PEEP or a high tidal volume, that will cause hypertension in these patients. So if none of them are there, please look at the drains. If patient is oozing a lot from the drains, hemorrhagic shock, you need to think of heparin as a first reason and second is dilutional coagulopathy. So I think other than that, most of the things have been covered.
So moving forward, suppose this is the X-ray of the patient. What is the most significant abnormality do you see and how will you manage it? Please answer in the chat box. So getting some answers. High position of IABP balloon. Can anyone tell me in which inflation deflation the X-ray has been taken, or at the time of the X-ray the balloon position, status of the balloon, inflated or deflated?
Now, basically means diastolic phase or systolic phase of the cardiac cycle.
So inflation means, as sir asked, which phase, systolic or diastolic?
I think those who know the IBP, they are already writing it as a
Yes,
diastolic phase.
diastolic. Yes. So all of you are right. So suppose whenever you have hypotension, while you are looking at the drains, also see, as ma'am rightly said, for the faulty ventilator setting, faulty IABP settings, from zero to each and everything, from technical aspects to each and everything you have to cover. And meanwhile, you do the X-ray and you see there is a high tip of high malposition of the IABP. You need to manage it. Okay. You need to withdraw the IABP. Sorry. Any other expert comments from Meeta ma'am and sir on this particular X-ray? If suppose sometime you get IABP malposition.
Yeah, so you need to, most of you have seen that the tip is high. Very important thing, if you missed it, to look at the left radial or left pulse, especially if the patient has radial artery removed as a graft, its hand is going to be compromised because this very high tip of the IVP is going to compromise the circulation of the left side. So that is one important thing you must remember.
Because the tip is going into the arc of the aorta, and this it is, I would say, very proximal before the distal subclavian vein origin. So it is going to be hamper the circulation of the blood, subclavian artery, sorry.
The ideal position is 2 centimeters below the height, the highest point of the arch of aorta here, which is seen. Someone said pneumothorax. Now, don't make that mistake. The diaphragm is, I hope you're saying it is on the left side, but you're seeing the bronchovascular markings throughout. The diaphragm is not low. It may look like a deep circle, but not very clear. So, really, there is no reason to think of a pneumothorax here. It,
Yeah,
but
also,
it's-
yes, sir, yes, sir. Finish it, finish.
yeah, on this X-ray. But in a patient who comes with hypertension, definitely will think of over
Emotion.
etc.
Yes, also someone had written the phase of IBP in this is systolic. I think you should get your concepts clear about IBP. This is not a systolic phase, this is a diastolic phase.
Moving forward, X-ray of the another patient with IABP. What do you think? Please write down, type in the chat box your answer. It's a X-ray of the another patient, not this patient, but just for the clarification of your IABP knowledge, I just put it over here.
What's the most significant
Abnormality.
abnormality? Because there are many, but what's the
Yes.
most significant which you would be worried about? Srinivasan is right. Pankaj is right.
So now all of you are said it is very low. So what kind of features or what complication it can give you? Because if you suspect, if you've seen the X-ray, now what things you would suspect in this patient?
I think Harry has written compromised renal function. That's correct. Any other? Yeah, you all are right.
Race.
Kidney function will be compromised. Anything else? I think you should not randomly write splenic infarct, liver infarct. How does it? Yeah, that's correct. Mesenteric ischemia could be there. Bowel ischemia could be there. Okay. Anything else? So basically, you all need to know what are the branches of abdominal aorta. Because if that is going to get compromised as it goes down and your balloon is occluding that, you have to think of that. Like paraplegia. Spinal artery can get compromised.
Any expert comments from sir on such X-rays, sir?
No, I think that is the most important thing. There is, of course, a valve, metallic valve that is seen. And you're seeing these opacities on the right side, on the left side. Difficult to say what it is because there is no a mediastinal shift to suggest.
It could be pneumothorax because patients, like in such cases where they open it for valve, because I can't see anywhere the clips. So it's probably the valve surgery alone. The nick to the pleura can cause sometimes pneumothorax.
True. That's most like this is not like a collapse. No,
No.
No.
it doesn't look like it because the mediastinum is not shifted, and
Yeah.
but
Nice.
bleed to cause mediastinum push to the other side. But yes, it most likely it's and it cannot be a pneumonia so soon after if it's
Sir.
so yeah, I think that's what it is most likely.
So after IABP part, we are moving forward. After reposition of the IABP, still patient is hypotensive and there is 300 ml per hour of blood in chest drain in last 2 hours. What are your concerns and how will you manage it? All of you said bleeding. So in earlier chat box conversation, so it could be bleeding and bleeding may be of surgical or non-surgical type. The excessive post-operative non-surgical bleeding, it is related with the impaired coagulation, fibrinolysis, and dysfunction of the platelets. I would say qualitative dysfunction, not quantitative. And some technical and disease-specific issues you need to include. These are systemic hyperinization, hemodilution, as ma'am said, dilutional coagulopathy, hypothermia. Few of you written hypothermia possible causing post-operative period and increase with the bypass duration. Antithrombotic drug therapy, antiplatelet therapy. Maybe patient sometimes there are some need of emergency CABG in some patients, and patient may be on antiplatelet clopidogrel, aspirin, or heparin also, and such. Sometimes they need to be taken for the emergency bypass surgery. So there are risk for all these bleeding factors. Now, how can you manage? You need to see the body temperature. If it is less than 35.5 degree, you need to rewarm the patient. Do coagulation profile, PT, INR, APTT. You can treat with FFP, but again, be careful because FFP, volume of the FFP is needed to correct your coagulation factor is very high. So sometimes prothrombin complex concentrate is highly helpful in such patient with low EF and risk of fluid overload. Okay, platelets, if they are low, you need to transfuse the platelet. Again, alpha aminocaproic acid you can use in such patients to prevent or to decrease your bleeding. So, and more important, if you need to give protamine, if you see APTT is because sometimes patient on cardiopulmonary bypass for longer duration of time and improper correction of the this realization, that's why patient may have bleeding. But again, remember, excessive protamine can also lead to the bleeding in such patients. So the question is, you are
Vivek,
yes,
I
please.
just want to put a comment. No, nothing
Yes.
to add per se, but I think it is very important point which you have written here is about the hypothermia and patients are coming post CABG in the ICU. I don't know how many of you know that they always put a rectal temperature probe for the core temperature to be monitored, and this is very important. The reason for post CABG patient or post open heart surgeries to monitor hypothermia is one of the most important. Yes, Vivek.
Yes, ma'am. Moving forward, when to reoperate. See, you are on duty, consultant may be not there in your ICU, and you are communicating with them. These are the blood loss, these are the chest drains. Now the question surgeon will ask, does it look like, or when you need to tell them that you need to reoperate or re-export this patient? I would like to ask all of you, please write down in the chat box, when will you call for re-exploration or reoperate this patient?
So basically indications for re-exploration.
Yes. Because all of us must know When we receive the patient, most of the time you may have gone through or you have not, but maybe in future you may go through that. Require patient requires re-exploration. The cardiac tamponade, not able to control with drugs, hypotension, non-responsive to 500 ml of fluid, massive significant bleeding for more than 2 consecutive hours, drain output 150 200 ml per hour, excessive drain fluid, more than 500, blood loss more than 400 ml per hour. Okay. So basically, the indication for re-exploration, bleeding unresponsive to medical therapy, cardiac tamponade, all of you are right. Bleeding rates 400 ml per hour for 1 hour. These rates are very important to know. 400 ml per hour for 1 hour, 300 ml per hour for 2 hours, and 200 ml per hour for 3 hours. These are the latest guidelines for the bleeding rates. Be careful if sudden decrease or total cessation of the mediastinal drainage, because 5 minutes back you were having a mediastinal bleeding in the drain, 5-10 minutes back, and now the drain is not coming. So possibility of blood clot is there, and it is getting the tube is chest drain is getting blocked by the clot, and it will lead to cardiac tamponade. So that's why you need to be very careful while you are monitoring or observing the chest drains. I would also like to have expert opinion and comments from sir and ma'am on this point.
Yeah, so one, I think the most important issue everyone has spoken about is the bleeding, basically hemorrhage, which is ongoing. But other than that, I think if the patient is showing a reinfarction, that means the graft shape blocked or grafts are non-functioning. And that is another reason we have taken the patients in operation theater to redo the grafts. I think that is very important to remember. Of course, this is the most visible thing. You will always think that despite giving everything, the bleeding is not getting controlled. But if it is very obvious that patient is infarcting or there's not much bleeding and patient continues to be hypotensive and there are some plus minus changes, that is one of the important indication that maybe your graft is non-functioning or malfunctioning. So I think that is one important reason. One comment I wanted to say, someone had written that if it is a hypotension and you give 500 ml and patient doesn't respond, I don't think you didn't take patients for such small reasons for reoperation. So I think even if you're writing some comments, just think it's a massive surgery. CABG is it comes under the category of supra major. The patient who's come from the OT. Now you want to take the patient again in the operation theater. So whenever you're writing some comments or your answers, just think before typing.
Moving forward, I hope all of you have cleared your doubts regarding re-operation or re-exploration. The indications are this, and the most important one, as ma'am said, graft failure, graft spasm, or non-functioning of the graft. Besides this indication, now bleeding has stopped. Now after 1 hour, patient again develops hypotension. Right? Heart rate is 104, BP 70 systolic, CVP is 17, and this is the ECG of the patient. Please comment in the chat box. What do you think? What do you see in this patient, and how would you take or manage this patient? Bleeding has stopped. After 1 hour, patient again develops hypotension. Heart rate 104, BP 70 systolic, CVP is 17.
Don't put question marks. We are asking you. So you don't answer and put a question mark on that. Yeah, these are all the ones who have already passed the exam. So they're writing it correct.
Okay.
Ved Prakash, bleeding has stopped now. So how can bleeding be responsible for hypotension?
So most of you correctly said, low kick oil, electrical alternance, likely pericardial, effusion and causing cardiac tamponade. So if you see here in ECG, you can see low voltage, and you can see in V2 very clearly. In somewhere in some leads, you will not find it very easy. V2 you can see electrical alternance. Okay, low voltage ECG, hypotension, tachycardia, high CVP. See, in post-op CABG patients, in cardiac tamponade, generally what happens, the pressure equalizes in all four chambers. But in post-CABG, sometimes it becomes very difficult to get all this equalization of pressure. So you may have only CVP, which is very high, and hypotension, tachycardia, low voltage ECG, and you may have electrical alternance in the ECG. So overall, it's a cardiac tamponade, but expert comment from sir and ma'am on this point. Cardiac tamponade, post-op.
No, this is right. Actually, your question itself is giving hint that bleeding has stopped. Now, to stop the bleeding, you must have done something. One of the things is, other than giving drugs like tranexamic acid or FFP, etc., people, there is one trend in cardiac surgeons that they clamp the catheter for a while if it is bleeding to allow it, and then they release. They clamp and they release. So that is one. I don't know what mechanism is there behind that, but if there is too much of bleeding, at least I have seen many cardiac surgeons doing that. And along with that, if you give drugs like tranexamic acids or FFP, or you're reversing any coagulopathy, then the risk of clotting the tubes is very high. So your question itself is telling that if the bleeding is stopped and CVP has jumped and patient has developed tachycardia, will be the very early sign of this kind of a problem. And yes, Vivek said it's visible in V2, but also if you see in long lead 2 and V1
Yes.
also, I mean, there is a long lead 2 and long lead V1, which you can say at the bottom of the ECG. There also it's easily visible, the electrical alternance.
Glenn has written T-wave alternance. There is
Yeah, Clem, yeah, it's not T wave, it's R wave alternance.
Can I
So,
add?
yeah,
Sorry, Vivek, Aditi here. Hi.
yes,
Hello.
Aditi.
So just wanted to add, whenever, just one thing for everyone to remember, we classically think of cardiac tamponade as pericardial effusion all around the heart. One thing you'll need to know, there's something called regional tamponade, especially in patients who had open heart surgery. For them, and tamponade we know is the collection of pericardial fluid as quickly as possible. That will cause, it's not the actual amount, it's the rate at which it fills. In patients who have undergone CABG or a valve replacement, any open heart surgery, you have to realize that even some amount of blood or a blood clot that accumulates on one side, maybe see on the free wall of the right ventricle, is enough to cause a tamponade, a hemodynamic instability, and they do not necessarily have to have fluid all around the heart. So please be aware, and this can be diagnosed more with TEE, transesophageal echo, and not so much on transthoracic echo. So if your patient, you have no other reason why your patient is hypotensive, you are not sure, because clotted blood may not look hypoechoic on the ultrasound, on the echo. It may still look like it is grayish. So you need to do a transesophageal echo in these patients, and when you have a high index of suspicion of what is called regional tamponade. And a lot of time, the regional tamponade is in the back of the heart. So your transthoracic echo does not pick it up. So just remember something called regional tamponade in CABG patients.
Yeah, very good point, Aditi. Thanks for that. Another thing, although Dr. Vivek has given this ECG, with such kind of a scenario, you must keep in mind, as I previously told you about the arterial grafts and all, especially if the CVP is gone up, think of a right-sided graft closure.
So thank you, ma'am. Thank you, Dr. Aditi. And now moving forward to our, so you do echo, you can see sometime swinging heart, you can see massive pericardial effusion. And again, as Dr. Aditi rightly said, sometimes it's on the posterior side, you will not be able to do with the transthoracic, so transesophageal echocardio if needed in such patients. So be careful while you are having a patient, hypotension suddenly develops, again improves, and after bleeding has been stopped, you need to think about tamponade and be careful, because ECG, each and every time you will not be able to take out the ECG. So keep a very close watch on ECG monitor, ECG monitors particularly, and look at the voltage of the ECG on monitors. Patient has been taken for the re-exploration, post cardiac tamponade. Now, post re-exploration, patient shifted back to the ICU on high dose of injection noradrenaline. BP is 80/50, CVP is 3, pulmonary capillary wedge pressures 6, cardiac index, you have that modality of hemodynamic monitoring. Cardiac index 4.5 liter per minute per meter square, and systemic vascular resistance, that is 400 dyne per second per centimeter squared. So the question is, what do you think is happening with this patient, and how do you treat this? So
Yeah,
for that,
basically interpret your hemodynamic monitor.
hemodynamics, yes. So it's a very, if somebody has undergone the, I would say that our orientation program, they must be knowing. So please write down in the chat box. Hypovolemia, vasoplegia. I'm waiting for your answers. Please
Only
write
two
down.
people have answered.
Yes. So many of you rightly said it's a vasoplegia. Okay, severe vasodilatation, right? SVR is very low. You can see the cardiac index, which is 4.5 supranormal. I would say just above that normal limits of per liter. But if you see the CVP, pulmonary capillary wedge pressure, everything is low. So severe vasoplegia. So how do you treat severe vasoplegia? With high vasopressors. I would also to have comments, expert comment from Meeta ma'am, Dr. Aditi Jain sir on particular such conditions.
No, rather than comment, I think I would ask, suppose this is a vasoplegic syndrome like vasoplegia. Patient is already on high noradrenaline. How would you proceed now?
Please comment in the chat box.
What was the heart rate of this patient at this time? Would you have an idea? It's okay.
So many of you are writing sepsis, SARS, post cardiopulmonary bypass. Yes. Regarding SARS, just beside with this topic. Okay, we will discuss about SARS in next few slides. It's fine. Vasopressin. So many of you have said vasopressin. Any expert comment from?
I would like to ask Meeta, couldn't we give fluids to this patient?
100%, sir. If there is no contraindication, only one contraindication could be a low ejection fraction. Still, we can give fluids. So
And
number one,
using dobutamine, because
not at this stage, sir. Not at this stage.
no, I'll tell you why. I know that there will be a vasodilatation and the systemic vascularization could come down, but it will increase the heart rate, it will increase the preload, like giving
No,
fluid.
sir. So improve the cardiac contractility only if there is an issue about the cardiac contractility, and maybe little later we would add dobutamine, but not at this stage in the beginning. But of course, it's a good
Would you
point to
consider
add.
methylene blue
Yes,
at this
I was
stage?
just coming to that. I was just coming to that only. So one is fluid resuscitation, vasopressin, you have already said. So you also give something called modulators of inflammation and nitric oxide. And one of them is, as Dr. Aditi said, methylene blue is very safe to give. It really helps. One is methylene blue. Another, some studies have also shown about thiamine, sometimes high dose vitamin C that, and No, finish with everything, then think of corticosteroids as a modulator of inflammation in these cases. But yes, methylene blue has definitely role.
Any other comments from Dr. Aditi, Dr. Jain sir on such cases?
No.
So, as ma'am said, methylene blue, you can sometimes use steroids also. Yes, particularly SARS, if it is happening with the SARS, you have to sometimes, my personal experience, sometimes patients just come to the ICU and they start spiking fever. Though sepsis is not there, so every parameters has been checked, PCT and everything, cultures has been sent. But sometimes it turned out to be only and only SARS. Then we need to give low dose of steroids to prevent and to control that surge. So yes, steroids can be useful. Again, the fluid first thing, then vasopressors, then methylene blue and steroid. These are the four things you need to keep in mind. But again, go with the patient's clinical condition after physically examining the patient.
I
Yeah,
think
someone is asked about the methylene blue dose. I don't exactly, you can correct
10
me,
mg,
Aditi.
10 mg per
It's,
kg.
I think a bolus would be, I think, 2 mg per kg bolus followed by infusion.
10 mg per kg has been given in the latest guidelines of the methylene blue.
Acha, because what we used to do is 2 milligram per kg as a bolus followed by continuous infusion.
Okay.
You can look into. You can look into.
I have also used the same dose, ma'am. But I've not read the latest. If Vivek has read it, maybe it's changed.
Yeah, exactly. Because what we have used is 2 milligram per kg followed by infusion. We can just check it.
Yeah, I just saying that Pankaj wrote that you should check about pre-op steroid dependence. If this was an asthmatic and he has undergo stress, then they can have adrenal insufficiency from the, in fact, suppose he's an asthmatic or COPD, he could have this. So,
I mean, yeah, it's a good thought. But anyways, I think low dose steroid will have role if these things don't work. Dr. Vivek has already said that. So I think, yeah, that is true. And of course, don't forget about thiamine, really, especially like if you're saying if patient has a pre-op history of asthma, same way if the patient has a pre-existing long admission in the ICU with patient being on diuretics and other things,
Yes.
these patients are prone to develop severe thiamine deficiency.
And many patients may be undergoing CABG are with the low ejection fraction, and that's why they must be, most of them are on the diuretics. True, ma'am. So moving forward, so you diagnosed clearly this is a vasoplegic syndrome. You treated with fluids, methylene blue, vasopressors, and steroid. Okay. Now, as ma'am said earlier, myocardial ischemia and myocardial infarction. The important, as ma'am said, it is very important to recognize it early to prevent myocardial infarction, particular myocardial ischemia. So the possible causes, we all know, imbalance of the supply and demand. Okay, it will cause some myocardial ischemia, any spasm of the coronary artery, thrombosis, and occlusion of the graft failure, and any other mechanical issue. So you need to know while you are treating the patient with hypotension or post-op, you see any ECG changes. I'll be just telling you in the next few slides about the ECG, because see, myocardial ischemia and infarction, it is very important to recognize or identify early, but it is very difficult to find out, because during intra-op, the cardiac handling is very high. That's why ECG changes, subtle changes are going to be there. ST changes, depression, elevation. So you need to be very careful while you are suspecting myocardial ischemia infarction in such patients. So how to diagnose myocardial ischemia? Any unanticipated myocardial failure, any particular ST changes in pattern consistent with the distribution of the coronary artery graft. If RCA graft has been, sorry, if RCA graft has been grafting has been done, so you need to see the changes in the ECG leads 2, 3 AVF. If there are ST elevation, ST depression, you need to be very careful with the particular graft, the distribution of the coronary artery graft. Any episodic changes, ST elevation or depression, which is highly indicative and possibility of coronary spasm is very high in such patients. And you do echo and you find any new wall motion abnormality, regional wall motion abnormality, would be suggestive of any myocardial ischemia and ongoing infarction. And if patients are awake post extubation, your patient is now complaining of chest pain. No, sometimes we think that it's because of the sternotomy has been done and patient is complaining of chest pain, but no. Always be careful. Keep a very low threshold for taking the ECG and diagnose the patients. Again, Careful about the anemia, keep the HB more than 8, prevent tachycardia, okay, and hypotension in such patient. So I would also like to have expert comment from Meeta ma'am, Aditi, Dr. Aditi Jain and Dr. Jain sir on myocardial ischemia and infarction.
Yeah, I think we already covered it, but I am again repeatedly saying you must know what kind of a graft have been put. And as I told you in the beginning or only, if the patient develops hypotension, the area where patient has arterial graft has a higher risk of non-functioning. So you must look for those areas ST elevation in such patients. There is no role of any cardiac enzymes because there is so much handling occurring during the surgery. So that is very important. Just going out of this, I think Pankaj has asked about the myocardial stunning. Vivek, are you covering myocardial stunning or?
You can.
Okay, so once we finish, I'll take it. So let's not confuse it.
Okay. So moving, Dr. Aditi, any expert comment from your side?
No, you've covered everything. Thank you.
Diagnosis of MI. So AHA and European Heart Association, they came up with the classification of myocardial infarction. They say it type 5 myocardial infarction. This is post cardiac surgery myocardial infarction. As ma'am said, it is very difficult to find out with the, I would say, biomarkers, cardiac biomarkers, CKMB, tropi, highly HS tropi, highly sensitive tropi. Because of the high handling of the heart during the surgery, it is going to be very difficult to diagnose. They come up with the guideline that saying increase in biomarkers more than 5 times of the 99th percentile of upper limit, upper reference limit during the first 72 hours after CABG, plus either new pathological QFs or new LBBB. Any angiographically, if you go and do the CAG, new graft occlusion or native coronary occlusion, or in imaging, if you see new loss of myocardium have been designated. So these are the changes that you may see in patient, and these things you need to keep in mind. CKMB tropi post surgery within 72 hours, biomarkers more than 5 times of 99th percentile during of the upper reference limit in first 72 hours, plus new pathological QAs or new LBBB. Though you may do not have all of them, you may have post-cardiac CKMB tropi not in that more than 5 times of the 99th percentile of the upper limit, but still you may have myocardial ischemia. So be very careful and very low threshold for diagnosing post-cardiac surgery myocardial infarction in such patient. As ma'am said, particularly look for the graft, the region of the, I would say the in ECG, see the particular walls, inferior wall, anterior wall, the leads of the walls. So determine accordingly you can diagnose the this myocardial infarction in such patients. Any expert comment from Meeta ma'am, Dr. Aditi?
No, I think you've covered it.
So how to manage that post this one, post CABG myocardial infarction? Control the tachycardia, as we said, it will increase the demand. Normalize the BP, reduced end diastolic pressure with the vasodilators, and if hypertensive, reduce the inotropes. Correct the hypotension if patient is hypotensive. Okay, could be hypotension possible due to hypovolemia or ischemia, but you need to correct it, hypotension. And beware, inotropes may increase the myocardial oxygen demand. Be careful while using the inotropes. You need to go down with the inotropes and administer aspirin if bleeding is controlled. Now, if you do each and everything as we said, and still patients are the conditions and the measures are ineffective, what you can do, you can, if IBP is not there, you can always go for IBP in such patients, and that will allow and that will help to winning of the inotropes. Consider surgical intervention, reexploration of the malfunctioning graft if suspect, and again in some patient, if it is very high risk for reexploration, you can go with the PCI in such patients. Any further expert comments on this point from Dr. Meeta ma'am, Jain sir, Aditi, Dr. Aditi?
No, I think it's fine.
We are almost covered everything in this the 30-40 minutes. Post-operatively, the things you need to carry in ICU, the first hypotension, all these things, and then fast hug beat, the common thing, sometimes we miss it, feeding, analgesia, sedation, thromboprophylaxis, ulcer prophylaxis. So these things you need to keep in mind. You daily need to check all these things. Try to prevent arrhythmia, because at most of the patients are highly prone for the arrhythmia, particularly atrial fibrillation. Early initiation of beta blocker, and if it contraindicated, then go with the amiodarone accordingly, BP and thyroid status of the patient. Always try to avoid hypokalemia and hypomagnesemia, as we earlier discussed, because most of the patients are on diuretics, and that's why, and most of the post CABG or patients who are undergoing CABG are, most of them are diabetic. So there are risk of, as we, you may, if you may remember that particular hypomagnesemia data set, diarrhea, diabetes, 7Ds, daru. So if you see there is a already diabetic patient, so try to prevent hypokalemia and hypomagnesemia, because that can lead to VT, VF and atrial fibrillation with the electrolyte imbalances. Okay. The most important thing which you may come across, that is post-operative paralytic ileus. I am telling you, take it with a pinch of salt. Most of the patients are going to develop post-op paralytic ileus. So early mobilization, early removal of the ICD drains if not needed are very important in such patients. And if you really think that bowel sounds are slow, go with the enema, go with the suppositories and prokinetic agents anytime. If valve surgeries has been done, prevention of valve thrombosis is very crucial. So be careful, and sometimes the valve choking of the valves also happens. Patient becomes breathless and suddenly becomes hypotensive. So be careful while valve surgeries or repair has been done in such patients. Be cautious, though nowadays the trend is within few hours. I would say from 2 to 6 hours maximum, patients are getting extubated post-op CABG. Though risk is very low, but still be cautious for atelectasis because of the sternotomy has been done. The patient, because of the pain of the sternotomy, patient will be not be able to breathe properly, not be able to take inspiration properly. That's why they will develop atelectasis. So be careful for the development of atelectasis, pneumonia, and ARDS in such patients. Again, early mobilization and physiotherapy in ICU is very crucial in post-op cardiac surgical patients. Monitor, observe, and avoid AKI in all these patients. And most importantly, watch and monitor for sepsis and try to prevent healthcare associated infection or the ICU infection in such patients. With this, I'm covering all these things. Expert comments from our expert panel, Dr. Meeta ma'am, Jain sir, and Dr. Aditi would be appreciated.
I think it was wonderful session, very practical, Vivek, and I think that's what the candidates going for exams require and for the bedside. So very good. You handle most of the emergencies that they come across.
Yeah, I think it was a nice idea to take opinions slide to slide. So a lot of things were already taken care while the discussion was going on. So I think it was a wonderful idea that many times we miss out on the points that the questions are asked at the end, or there are many points we want to tell at that time. So I think it was wonderful idea to have discussed during each and every slide. So yeah, from my side, nothing to add. Once it is over, once Aditi also has anything to say, if not, then I can answer about that micro stunning thing.
Just to
Aditi, any
one announcement meanwhile is next week is the last round of that we'll have of candidates who have done FCCM who want to do a further fellowship in London there. So if someone has been missed out and they haven't previously given their name, please send me your name on WhatsApp and your qualification. It's not that it has to be post MD, even MBBS, but you have to be basically good at bedside care of patients and taking independent rounds. You need to do that. And it can be for 1 year, it can be for 2 years, it can be for 3 years. The person would get a salary which is a very standard NHS salary there. So you can contact me today, tomorrow, anytime.
Aditi, you want to add anything?
Aditi had to go off, I think. So,
Okay. Vivek, any more questions? I'll just meanwhile cover that question of.
Go ahead.
I think Pankaj
Can
have
I,
asked about.
can I ask one question?
Yes.
How do we prefer beta blocker and cardron in post CV patients? Suddenly, they have most of the patient AFib, but sometimes they have hypertension, sometimes they have PP is normal. Whether to correct potassium, magnesium, and then we prefer beta blocker, Or we start first with Cadron or beta blocker and then
Who is asking this question?
Sunil.
You will get them.
Okay. So it is very simple. Look at what is the hemodynamic status. Any tachycardia, you identify what is the abnormality later on, whether there is an atrial fibrillation or any other kind of an arrhythmia, or whether there is a hemodynamically compromised VTAC, whatever. If it is hemodynamically unstable, you have to cardiovert these patients, especially post-CABG patients. You have no option.
That's
Second, yeah,
what
if
is the
patient is
pressure here to cardiovert?
hypotension, so it has to be so again, if it is immediate post-op within 72 hours, because arterial grafts take 48 hours to switch over to the actual flow. So if it is an arterial graft, you don't want it to go below 100, the blood pressure. Again, if patient is hypertensive, then your threshold will be little more on the higher side. Of course, 100 would be cut off in especially patients who have arterial graft. If it is a venous graft, even 90 should be all
90.
right.
Okay, yeah.
Yeah. Second thing is, if patient is not hemodynamically unstable, then the choice between beta blocker and amiodarone, I think it's a very good question, because many times we see development of atrial fibrillation because these patients were previously on beta blocker preoperatively.
Yes.
And it is very important to really introduce beta blockers ASAP after the surgery. So in fact, we have had sometimes patients who are so dependent on beta blockers that we would start, although it's not there in the literatures, and we had many electrophysiologists in our team, they would start 1 milligram of beta block maybe every half an hourly or 1 hourly,
Yes.
just to prevent the development of atrial fibrillation. So you reintroduce beta blockers as early as possible. So if patient was on beta blocker, you could not introduce, or it just went out of your mind, and patient develops atrial fibrillation, think it is a beta blocker withdrawal. Meanwhile, as you rightly said, you have to look for the other causes like hypokalemia, hypomagnesemia. You start
If suppose,
correcting it simultaneously.
hypomagnesemia is there and we have to correct whether 2 gram, 4 gram, we have to give slowly or over 6 hours, 8 hours.
Always bolus followed by infusion.
How much?
So it can be 1 gram bolus followed by 6 to 8 grams, up to sometimes 10 grams. So it depends on what are you suspecting by the background. We have given patients up to 10 grams.
Diabetic patients or these patients.
Yeah, long-standing diabetics on diuretics. So if you have multiple things together, you can go up to even 10 grams if your potassium is not getting corrected by replacing. It's not that just for one first go only you start.
No.
So the only thing I think Dr. Prabhakar, so keep the potassium level more than 4. Keep the
Yes.
magnesium level on the around higher normal limit. So by doing this, you can prevent your atrial fibrillation, any other arrhythmias in such patients. Because this is what we do. Because there are sometimes a cardiosurgeon will tell that there is a fluid overload, okay, or there is a need of giving diuretics, Lasix. So try to keep it always potassium more than 4 in post-op CABG if it is not contraindicated with AK or any kind of chronic kidney disease, and keep lower normal or upper limit of the hypomagnesium level within that limit. So you prevent the hypomagnesemia in such patients. Because most of the patients receive diuretics in the next, I would say 96 hours post-op CABG, they would receive diuretics also, they will receive potassium correction also, beta blockers also. So it's very, I would say, minute and minute things are changing.
Yes.
In next hour, you will require fluid suddenly, you will require diuretics. So these are the things you need to keep in mind accordingly your hemodynamic parameters. But is to prevent atrial fibrillation, because the risk of stroke is very high in such patients. Suppose patients are having coronary artery disease or peripheral vascular disease, chronic smoker, risk of getting bilateral carotid artery stenosis or plaques are also there. Risk of stroke is very high in such patients.
Yes.
So be careful to such atrial fibrillation kind of arrhythmias. Thank you.
I had one question, sir.
Who is that?
Hello? Dr. Kishore, sir.
Doctor?
Dr. Kishore.
Kishore. Yes, go ahead.
I just want to extend the question of Dr. Sunil. The heart rate is too high, so it is 160, 170 with atrial fibrillation, with hypokalemia and hypomagnesemia. So mostly the potassium correction is given over the period of 3 to 4 hours. So should we allow the tachycardia for 3 to 4 hours?
No.
One, yeah,
It isn't You have to correct it over 3 to 4 hours doesn't mean you'll give it at 3. The moment you start, the first potassium goes intravascularly. Vascularly to interstitium, it doesn't take much time. And the fact that your potassium, suppose it is 2, will very quickly, within literally in minutes, go up to 3 intercellularly. But then again, it will fall. So, arrhythmias due to electrolyte imbalance, they correct very fast. It will not be that you'll have to wait 3-4 hours for them to correct.
Okay.
Yeah. So Kishore, you had two parts in your question.
Yes.
Number one, that you keep giving calcium, potassium, and magnesium. That is one. And the important question was, will you allow the tachycardia? See, there are two parts. If there is a hypokalemia which is causing tachycardia, you need to correct. And you need to correct continuously. It cannot be, as Sir rightly said, 3 to 4. It goes over 24 hours for 2 to 3 days. And that will take a time. So that is the basic reason. But till that time, you have to treat the tachycardia. You have to
Okay.
treat, if it is hypertension, give cardioversion. If it is good blood pressure, and if patient was already on beta blocker,
Then
so
we
first
can- yeah.
start with beta blocker. And if it is borderline and patient was not on beta blocker, you can start with amiodarone. So you have to control the heart rate. That is the priority. But the reason for the heart rate, the arrhythmias, if that is a hypokalemia, you need to continue doing that. So both the things go simultaneously.
Okay. So this cardron will apply also for low EF patient because cardron
In
is
low
some-
EF, in fact, you will give amiodarone.
Okay, madam. Okay. Okay.
Beautiful presentation, Vivek. And
Okay, sir. Because I know Pankaj must be waiting for that answer. Myocardial
Yeah.
stunning. So there are two things. There is something called myocardial stunning, and there is something called hibernating myocardium. Two things are there. So myocardial stunning is the thing where patient has ischemia, but there is no necrosis, and it's stunned. It's in the recovery phase. So usually it is seen in reperfusion. So you have thrombolized a patient, or you have done the patient's plasty or something. It will take little time. So you have to treat it like cardiac failure kind of a thing to support. So it's weak, and it will take days to weeks to recover the original. Your patient's ejection fraction may be, say, 25-30%, which will improve over a period of time, maybe days or weeks to come. But you will see that there is no, on echocardiography, the ejection fraction in general may look small, low, but there is no damage. The myocardium is well preserved. So that is about the stunning. And you need to support it. If it is immediate post-op, you need to support it, as Dr. Vivek has already covered. You control the heart rate, you control the blood pressure, you give aspirin, you give ACE inhibitors, very important, beta blockers, ACE inhibitors. And you just support the heart till it recovers. What is myocardial hibernation or hibernating myocardium is there is a chronically low flow. So basically, in these patients, it's almost like repeated stunning of the myocardium. So these patients require reperfusion. You need to send these patients for intervention, and they will take a longer time, to maybe up to months together, to come back to normal. So if the myocardium is preserved and it's generally looking a low ejection fraction, that doesn't mean it's a damaged heart. They will recover, but if it is stunning, it will be in days or weeks. And if it is a hibernation, it will take weeks to months. So that is about it.
yeah, myocardial stunning is after an acute insult. Whereas
Yes.
hibernation is after
Chronic ischemia. Yeah. I think there are no more questions. Vivek, in the chat box. Anyone has anything to say?
Dr. Ankur has joined. Welcome, Dr. Ankur.
Namaste, sir.
Anything from your side? Any expert comments?
No, I joined very late. Sorry for that. But I hope this was a very means awaited lecture. And again, from the student's point of view, I will request sir that the recordings of this will be available soon.
Yes, in few days, 2-3 days. Yeah.
Sir, with your permission, I have one question.
Yeah.
Yeah, we have been talking about this fluid. The fluid has to be given in vasoplegic. My question remains the same. If the cardiac index is normal, within normal limits, within normal range, then why do we need to give, especially if the patient is myocardial stunning or hibernation, or whatever situation? If the cardiac index is normal, why we should give fluid? Why not start vasopressin directly?
It's like this, Pankaj. If there is not this case, I'm just saying, if there is hypovolemia, the heart rate would increase to compensate for the cardiac output. So if you argue that if the cardiac output is okay, why are we increasing the preload? The cardiac output, the body is going to try and maintain by increasing heart rate and increasing the contractility by autonomic pathway and so many mechanisms. So by giving fluids, you're actually going to reduce the stress on the myocardium. So it's not cardiac output. The body will try to preserve cardiac output, but it's doing it at a cost.
So it's almost like Pankaj, there are two patients, both patients' saturation is 96%, but one patient's respiratory rate is 40 and another patient's respiratory rate 20. So you are not looking at the final outcome of 96. How much it is costing to reach to that 96 is important. I think you got it.
Understood, madam. Thank you very much.
Yes.
Thank you.
Yes.
So hope I have covered everything, and with the new idea of having expert panel discussion kind of a thing, I think this year with the starting of this year. And thank you, sir and ma'am, for giving your time for the expert panel discussion in such a beautiful and important topic for all the students and everyone, including me also. And I do learn every time from sir and ma'am whenever we hear from both of them. Special thank to Dr. Aditi Jain for their inputs and as an expert in this expert panel discussion. Dr. Ankur, though he joined very late, but single input, sir, we are waiting for your single input if you can give. Dr. Ankur Gupta.
Your mic is
Muted. Mic is off. Yes.
Or you who have listened this session, it was a wonderful section. But again, go and read from the book. It is very important. That's my only input.
Yeah.
But there are few things, because Ankur, you came little late, there are few things we really covered, practical points. Which may not be there in the book also. I'm telling you, there are so many important points.
But this I said, madam, because
You have to read the book. You have to read the book.
what I am seeing,
option.
and candidates are totally relying on our lectures.
No, you have to read the books.
So this is it's no suppose why certain it's like reading a book and seeing a movie. If you are reading a book, you have your sort of imagination, your thoughts of thoughts. If I say it's a beautiful sky in the night and the moon was there, stars were there, everybody who is imagining has a different sort of imagination and understanding. But when you see a movie, a night sky with a moon and stars, all of you have a single viewpoint. So when you read a book, you have a different sorts of doubts, different sorts, which can be clarified in these sessions. So what my point is, listening to these videos is very good and they are very practical but you need to get a basic of some theory part, which is in the book, which you people don't read, and then you get stuck up in the exam and asking in the viva and also in the theory paper. So
I
that's
think what
very
Dr.
good.
Ankur is saying is very important, that if once you listen to the lecture and then you go and read, it becomes so easy to understand. And those in between the lines which are there from the exam point of view or theory point of view is very important. So it will be very easy for you to now, suppose you go back and read the chapter on care of post-CABG patient, you will understand it better as compared to just reading it.
Yeah,
So-
especially because Dr. Ankur has already explained on ESPHCM why and how to read more about it. Thank you, sir.
So again, I
Thank
was
you.
trying to tell you, do more, read about it.
No, we had a discussion with P.K.Jain sir also. That is what I have told is again become an old concept. We will come up with a new one with sir and me. I decided that we'll come up somewhere in the late Jan with the new techniques of reading. Sir is having a very good research and planning for that. But at least you should read that much itself.
next week session is supposed to be on vasopressors and inotropes, and I will take that. I think it's extremely eye-opening lecture because it's one of the most confusing topics in critical care medicine. When to use it, how long to use it, when do you increase the dose, when do you reduce the dose, etc. And what are the things to look out for when you're giving these medicines. You do that. 7th, unfortunately, the next Tuesday is the 7th, and I anticipate that I may not be there available on 7th. So in that case, it will be on 8th or 9th.
So we can keep it. Yeah, we can announce it late. And as many of you will say ki we have had a session on vasopressor and inotropes, but trust me, this is different lecture. This is about the basic understanding of vasopressors and inotropes, not the one which you have already taken. Someone has already, yes, sir, someone has taken vasopressors and inotropes. But that was about application, not from the basics what you take.
Okay. All right. I like Pankaj whenever he says all said and done, I'm loving it. You know,
Yeah.
just meeting all of you is very encouraging.
Thank you so much, sir. All the best.
Thank you. Thank you. I'll just close now.